Next, we'll talk about 5-fluorocytosine very briefly. 5-fluorocytosine is a fluorinated pyrimidine, analog of cytosine. What the drug itself is not active as such. It has to be converted to the active molecule. And the first step is a deamination that happens inside the fungal cells. The deamination doesn't happen in the mammalian cells, and that is the reason why this is a selective drug. It has selective toxicity to the fungal cell. So the deamination converts 5-fluorocytosine to 5-fluorouracil. And you have already studied 5-fluorouracil as a chemotherapeutic agent, in fact. So when you want to treat cancer, you directly give 5-FU, 5-fluorouracil. But if you want to treat a fungal infection, you give 5-fluorocytosine because it can only be converted to 5-FU inside the fungal cells. And of course, it also requires a permease to internalize it, and we said the aminase to convert it. And then the 5-fluorouracil follows the same pathway you have studied before for antivirals and for cancer chemotherapeutic agents. It is converted into the triphosphate form, 5-fluorodeoxyuridylate, and this compound inhibits thymidylate synthase and therefore interferes with the synthesis of DNA mainly, but also with RNA synthesis. So the 5-fluorocytosine, in fact, is not used as a single agent alone to treat fungal infections because resistance is very common to it. It is used usually in combination with amphotericin B for a serious condition called cryptococcal meningitis. Its main toxicity is bone marrow toxicity, and you'll tell me how come. You just said that it's not converted in the mammalian cells. It is believed that this can happen because of conversion of 5-FC to 5-FU by bacteria in the gut. And this then you start absorbing 5-FU, and this goes to the bone marrow, which is susceptible because it has a high turnover rate, and you can get pancytopenia with this treatment. And this is a summary. You've studied this before. 5-fluorocytosine converted to 5-FU, which then can either inhibit RNA synthesis by being converted to the triphosphate form, or by a reductase gets converted to 5-fluorodeoxyuridine monophosphate, which then inhibits the synthesis of thymidylate, which is incorporated in DNA. That's enough for 5-fluorocytosine. The azoles are the other big class of drugs used to treat fungal infections. And as we mentioned, their main mechanism of action is to inhibit the synthesis of ergosterol. And they do this by inhibiting an enzyme called 14-alpha demethylase, a cytochrome P450 enzyme. As a result, you get accumulation of precursors which can affect the activity of certain enzymes, as written here, that are important for the growth of the cell. So these drugs are not fungicidal. That's their main limitation. They're fungistatic. And that's why you prefer to use amphotericin B for serious and life-threatening infections and infections in immunocompromised hosts. However, they have their uses, of course. Why are they selective? Because our cells can incorporate cholesterol from the environment, from the surroundings, whereas fungi have to synthesize ergosterol de novo. Now, this inhibition of this enzyme, these are enzymes that are also involved in steroid synthesis, however, in humans, and you will interfere with the synthesis of certain steroid hormones, including the adrenal steroids, as also some sex hormones. So you will see a lot of endocrine effects with some of these agents. In addition, the inhibition of the cytochrome P450 enzymes can lead to multiple drug interactions, as you learned earlier in the pharmacology course. And resistance does develop to them through a number of mechanisms, similar to what you've learned earlier such as overexpression of the target or efflux through a pump. So here is the synthesis of ergosterol, and we have various compounds that can inhibit ergosterol synthesis. We'll mention them. We're dealing with the fluconazole, the azoles, which is exemplified by fluconazole, and this is the step, the conversion of lanosterol to dimethyl cholestatrienol. This is where you interfere. There are others, like one we mentioned earlier, terbinafine, which interferes at an earlier step from squalene to squalene epoxide. And there are others like morpholines. They are not used systemically in humans, and they're also used in, I think, as for plants and other applications. Ketoconazole is the original azole. It's the oldest, but also the most toxic, but the least expensive. Nowadays, it's rarely used. You'll, except in some places in the world where price is a primary concern, cost is a primary concern, perhaps. Uh, it has a variable absorption, like many of these drugs. It is better absorbed in an acidic medium, in fact. However, one of its limitations is its inability to cross well into the blood through the blood-brain barrier into the CSF, and therefore limited in treating CNS infections. As we said, it's metabolized by CYP450, but it also inhibits some of these CYP450 enzymes, and therefore causes a lot of drug interactions. It has these therapeutic uses for certain fungal infections, but as again, not in the severely ill or immunocompromised. It has many kinds of formulations. It can be given orally. It can be given locally also as topical agent. Because of the many side effects it has, it's no longer a drug of choice. These adverse effects include GI disturbances, as many drugs do have this adverse effect, but also the endocrine effects, which include adrenal corticosteroid synthesis and sex hormone synthesis. In terms of sex hormones, you could have menstrual abnormalities in women, gynecomastia in men, decreased sperm counts, decreased libido, decreased potency. In terms of the adrenals, the inhibition of adrenal corticosteroid synthesis can lead to accumulation of precursors that have sodium retaining activity, like aldosterone, if you've heard of aldosterone. It's the normal hormone produced by the adrenal cortex. Uh, but some of the precursors also have this activity. So when they accumulate, they can cause fluid retention and can cause hypertension and can worsen hypertension in people who have it already. Uh, Also, a very disturbing and serious effect is hepatitis, which can be very severe and fatal, although it's not very common. And multiple drug interactions can happen with ketoconazole, as well as the fact that it's teratogenic, which also adds insult to injury. The triazoles are exemplified by itraconazole and others we will mention. Now, again, this, like ketoconazole, has a varied absorption, but in general has less endocrine side effects. They do occur if you use higher doses. So it's a relatively safer drug, less hepatitis as well, and it has a good spectrum, a wider spectrum. So these are some of the conditions you can treat with it. Uh, but again, all the azoles, you should remember, all the azoles have the potential to have multiple drug interactions due to this inhibition of cytochrome P450 enzymes. Another triazole is fluconazole. Now, fluconazole even has less endocrine effects than itraconazole. And what's advantageous about it is that it can penetrate much better into the CSF relative to the other two drugs. it's also much better absorbed. And so, in general, it has less adverse effects, both endocrine and GI. Nevertheless, its problem, or not problem, its limitation, it has a narrower spectrum. But the fact that it can penetrate into the CSF makes it effective in certain kinds of meningitis, fungal meningitis. The drug interactions remain, although less of a a weaker inhibitor of cytochrome, but still you have to keep them in mind. You cannot just disregard these interactions. Voriconazole and posaconazole are newer agents, again, wider spectrum than fluconazole, and they have their own peculiar toxicities. You don't have to memorize these two drugs. Visual disturbances for voriconazole, for example, um, and again, the drug interactions, remember them. Now here are, this is another agent that is used for, sorry, this slide is out of place, or I changed the slide into two other slides, so forget about this. Griseofulvin is another compound that has a very limited use. Basically, it is used to treat infections of the skin, hair, and nails that are due to dermatophytes. So you will learn these later on in dermatology. Agents that affect, these are fungi that affect the skin, hair, and nails, referred to as tinea capitis, tinea corporis, tinea, etc. However, the mechanism of action of griseofulvin is interesting. It's similar to what we discussed previously for the vinca alkaloids and for colchicine. It seems to bind to microtubules and disrupts mitosis of these cells. Now, this is a drug that is given orally, systemically, and what it does is that it distributes the various tissues, but it gets concentrated in keratin layers of the body. So skin, hair, nails, concentrated, and therefore it has that's where the infections taking place, and the dermatophytes actively concentrated, and as a result are they stop growth. Now the thing is, you have to treat, when you're treating these kinds of infections, you treat for a long period of time, because you need for new skin, new hair, and new nail to grow that is free of infection until the old nail that is infected is shed totally. So when you're treating, for example, a hair infection, you may need to treat for a month or so. When you're treating a nail infection, you may go on for 6 months or even a year if you're dealing with the toenails, because they are very, very slowly growing nails. Um, Griseofulvin has a number of toxicities: neuro, hepatotoxicity, photosensitivity, and it is carcinogenic, at least in experimental studies. Another drug, also for the same indications, the dermatophytes, is terbinafine, and this is a drug that we mentioned previously, working by inhibiting ergosterol synthesis at an earlier step relative to the azoles. Again, the same concepts apply here in terms of treatment and prolonged treatment. The echinocandin antifungal drugs are a relatively recent addition to this armamentarium. What do they do? They inhibit an enzyme in the cell wall responsible for formation of cell wall glycans. So its target is a complex of proteins responsible for the cell wall beta-1,3 glucan polysaccharides. Again, this is intravenous only, and there is some resistance that can be encountered. It has a limited use for aspergillosis and candida infections. The drugs include, these are the various drugs: echinocandins, capsofungin is the original drug that was synthesized. So here is the target of uh, the drug. Uh, the enzyme that they target is in the cell membrane. It's referred to here as FKS1P and 2P. This is the enzyme that synthesizes the 1,3-glucan, which is important for the integrity of the cell wall of the fungus. Okay, when they inhibit this enzyme, you interfere with the synthesis of the cell wall, and as a result, and this is a depiction of a schematic figure representing the interlacing of the cell wall with the BD glucans, beta glucans, 1,3 and 1,6 glucans. So this phospholipid bilayer in the cell membrane contains the protein, which is the target for the echinocandins. They have a number of adverse effects, including fever and chills, which are common and can be managed with drugs. A headache also is common, and this is one of the drugs that can cause release of histamine. We've studied this before. We noted that drugs like morphine can release histamine, others as well. This is one of them. And you get the symptoms such as redness, swelling, feeling of warmth, and itching. Liver toxicity and hemolysis may occur as well. Now, the topical antifungals are drugs that are used topically, as the name implies. So, either as creams or ointments, or eye drops or ear drops, or vaginal suppositories. Uh, so we have all the classes that we have studied, mainly the azoles, the polyenes, and others like terbinafine and related drugs exist as topical agents. Now, when we talk about topical therapy, we're talking about the superficial layers, like the stratum corneum and the mucosa and the cornea, not the subcutaneous. If you have subcutaneous infections or hair or nail, as we said earlier, these cannot be treated topically. You have to use systemic therapy for these kinds of infections. So many azoles exist here. Uh, Nystatin is a polyene similar to amphotericin B, but it's even more toxic than amphotericin B. So it's not given systemically, intravenously. It's given topically. It also can be given orally. Orally, if you give it, it will not be absorbed. So there's no danger of toxicity, systemic toxicity. But you can use it orally, for example, as a solution if you have oral candidiasis or esophageal candidiasis to treat that local infestation. Let's ask this question. A 68-year-old man in the hospital because of a prostatectomy performed 4 days before. He is wearing a urinary catheter and is currently treated with a combination of broad-spectrum antibiotics. The patient has been suffering from chronic renal insufficiency for the past 2 years. Two recent urinalyses show many budding yeasts and cultures were positive for Candida albicans. Which of the following drugs would be appropriate for a systemic antifungal treatment of this patient? Of course, try to pose it and answer and analyze why. So the answer is fluconazole. Why is it fluconazole? Well, obviously this patient has chronic renal insufficiency for the past 2 years. So amphotericin B is going to be problematic in this patient because he's going to add injury to an already uh, compromised renal function. There is no serious infection here. It is a urinary tract infection, localized, and the person can therefore be treated with the alternative agents fluconazole, the azoles. The statin is not used systemically. Briseofulvin will not be effective because it's not effective against candida, and terbinafine also against. These are used against uh, dermatophytes, and both of them are toxic. So are not toxic to candida. Sorry. Okay, so this is an example of the application of this information in treatment of patients. Good luck.